Today, all rare communities worldwide join their voices together as one, hoping for acceptance, recognition, equality, understanding, better health care, swift and accurate diagnosis, and access to treatments. Welcome to the first patient-driven webinar organized by ImmunAID and the FMF&AID Global Association. This will be the first in a series of webinars. Thank you for taking the time to join us today. My name is Malena Betterly, and I will be your moderator. Before we continue, I will give the floor to Emna Shaban, who will give us a short introduction to ImmunAID. Please, Emma, whenever you're ready.
Thank you, Malena, for the introduction. So I will, of course, begin by introducing myself. So I'm Emna Shaban. I'm the clinical project manager of this huge project, so of the ImmunAID project. And so I'm working with Frédéric Perran and with my colleague Arturo Hernandez Cervantes, and we are building a cohort of patients suffering from these systemic autoinflammatory disorders, from these rare diseases. And it's by working with the FMF&AID Global Association that we identified the need to make these diseases and these symptoms known to pediatricians and to general practitioners. So we are very happy today to organize this webinar with the help of our ImmunAID experts, and I will make a very short introduction about this huge clinical project. So it is ImmunAID, so it is for Immunome, Consortium for Autoinflammatory Disorders. So it is a 5-year European project that started in 2018. So it's composed of 25 partners in 12 different countries. So what is the first or the main goal of this project? So it is to provide a novel diagnostic classification of systemic autoinflammatory disorders. So how will we achieve this in just a few words? So we are actually building a cohort, the clinical cohort of patients. The goal of recruitment, of patient recruitment, is to have about 700 patients. Actually, we have about 300 patients, so we are very happy about the progress of this cohort. So from these patients, we will collect samples. We will collect very precious clinical data, and we are sending them to 14 research laboratories all over the Europe, and so we will proceed to a deep biological exploration of these samples. We will study all the molecular, all the cellular aspects using different approach, using different technologies, and then all these results will be combined integrated in a global data set using machine learning technologies and computational analysis. And the final aim is to be able to find a common signature for these diseases, is also to make each systemic autoinflammatory disorder identifiable, and finally to be able to generate or to design an algorithm to guide the diagnosis and make it efficient and make it faster. So actually we are still on the recruiting phase. We have 36 recruiting sites, hospitals all over Europe. We have many clinical centers, as you can see here in France, and we have many others in all the countries that you can see here. We have great experts that are helping us to build this huge cohort every day. So here I put some communication tools. So if you want to know a little bit more about the project, you can directly connect to the site. If you want to have updates about the project, if you want to know about the next webinar, the next events, you can follow up on Twitter. And finally, if you want, for example, to participate to the cohort, or someone that are that is interested to participate, you can directly send us an email through this email address, and we will be happy to help. So that's all for me, and Malena, I let you continue. The floor is yours.
Yeah, thank you, Emna, for the introduction on ImmunAID. Today, we will be covering systemic autoinflammatory diseases, abbreviated to SAID. Since we only have 1 hour and we want each of the speakers to have enough time to present, we will start now with the presentations. On your screens, you should now see the agenda for today's webinar, as well as the names of the speakers. I'll start with a few introductory words on the patient needs, followed by 3 presentations. The first presentation is by Professor Tadej Avcin on introducing SAIDs, followed by Professor Sophie Georgin-Lavialle presentation on recognizing SAID symptoms. And lastly, Professor Isabelle Koné-Paut will present on access specialist SAID and patient-centric care. In the interest of good timekeeping, please save any questions you may have until we have finished our presentations. Anytime during the presentations, please feel free to drop any questions you may have in the chat box. The experts will try to answer your questions at the end of the presentations during the Q&A session. We will not be doing open mic questions. Without further ado, let's begin with the webinar. Next, please. So it's my pleasure to open this session with a few remarks on the patient's needs. As mentioned before, my name is Malena Vetterli, and I am the Executive Director for the FMF&AID Global Association, which was formed to address the unmet needs of autoinflammatory patients. Additionally, we serve as an international umbrella organization for multiple affiliated autoinflammatory associations in many countries and serving some 80,000 patients. This webinar is dedicated to the essential and most important role GPs and pediatricians play as the first point of contact for autoinflammatory patients, both in pediatrics and in adult age groups. Through this webinar, we want to raise your awareness and provide critical information so that you can identify patients suffering from symptoms of these diseases, provide basic testing to build a detailed medical record, and to refer and collaborate with appropriate specialists to provide comprehensive medical treatment in a timely manner. In most countries, it's either a rheumatologist or immunologist managing these cases. However, patients may also require specialists in gastroenterology, endocrinology, cardiology, etc., depending upon how the disease has manifested individually per case. Years ago, patient involvement in healthcare, research, or in events like this would have been unimaginable. However, with the ability to join online communities, access medical research, and many other resources, patients are more aware of how their disease expresses and strive for shared and positive decision-making strategies with their medical teams. It's now becoming much more common and accepted practice to involve patients in research. A good example is ImmunAID, where from the beginning they have involved the patient organization, FMF&AID, as a partner. As part of the ImmunAID project is to raise awareness. In my capacity as patient representative, I approached them and proposed to have a series of educational webinars presented by experts from ImmunAID on issues important to the patient community. Our suggestions were enthusiastically taken up, hence this series of webinars. One of the common issues we hear from patients is that they feel they are often not listened to, not believed, or not taken seriously. I hope the following presentations will help you understand better these diseases, the importance of prompt referral to the specialist, and to think out of the box, because with autoinflammatory diseases, each case is unique. So that concludes my introductory words on the patient's needs. I will now hand over to Professor Tadej Avcin to introduce himself and give his presentation on introducing SAIDs. Professor Avcin, you may start when you're ready.
Thank you very much, Malena, for this kind introduction. It's a great pleasure to participate at this webinar. I'm Dr. Tadej, pediatric rheumatologist and immunologist from Children's Hospital in Ljubljana, Slovenia. My task today is to focus on introduction of systemic autoinflammatory diseases. I have nothing to disclose that would relate to this presentation, and this is the outline of my presentation. First, I would like to present a concept of immunologic disease continuum for pediatric inflammatory non-infectious diseases, and then I will focus on systemic autoinflammatory diseases, particularly monogenic forms. So at the beginning, I would like to introduce the pediatric inflammatory non-infectious diseases that were traditionally classified as autoimmune diseases. For these diseases, it was somehow characteristic that they had antigen-specific activation of adaptive immune systems, such as autoreactive T cells or autoreactive B cells with autoantibodies production. On the other side are autoinflammatory diseases, and this term autoinflammation was first proposed in 1999. These diseases are characterized, in contrast to autoimmune diseases, by antigen-independent hyperactivation of the innate immune system. So these diseases are characterized clinically with spontaneous attacks of systemic inflammation, without any apparent infectious or autoimmune etiology, and they cause a production of inflammatory cytokines, including IL-1 beta, IL-1 6, IL-1 18, and so on. What activates this hyperactivation of immune system? This could be different endogenous or exogenous stimuli, and I would particularly like to focus on familial autoinflammatory syndromes. But first, I would like to show a concept of immunologic disease continuum. Based on what I showed about autoimmunity and autoinflammation, we can divide two groups of pediatric inflammatory non-infectious diseases as those that are driven by adaptive immunity or autoimmune diseases, and those that are driven by some irregularities, some disturbances in innate immune system or autoinflammatory diseases. The concept of immunological disease continuum somehow joins both views and states that most of the diseases includes both components, autoinflammatory and autoimmune components, with addition contributing factor of environmental triggers. To show this on a slide, I don't know if I have a pointer, but you can see on if you can see my arrow on this adaptive immunity side, you can see the monogenic autoimmune diseases, which are monogenic, inherited inborn errors of immunity involving T and B cells. On the other far end are monogenic diseases of innate immunity, so these common monogenic autoinflammatory diseases. In between, there are several much more common diseases, such as systemic juvenile idiopathic arthritis, Crohn's disease, and other diseases that share both components of autoinflammation and autoimmunity. Certain diseases are a little bit more linked to autoinflammatory sites, such as systemic juvenile idiopathic arthritis, and certain diseases more on the side of autoimmunity, such as, for example, systemic lupus erythematosus or myasthenia gravis. And on this figure, you can also see environmental triggers as an additional modifiers of this clinical phenotypic expression of these diseases. Regarding the systemic autoinflammatory diseases, I would like to focus particularly on monogenic forms of SAIDs. In 2022, we well characterized more than 45 systemic autoinflammatory diseases, and there is also a large spectrum of genetically undiagnosed systemic autoinflammatory diseases, such as Still disease, Kawasaki disease, recurrent pericarditis, and other. And ImmunAID project is designed also to somehow identify possible pathogenic causes, pathogenic mechanisms of these yet genetically undiagnosed systemic autoinflammatory diseases. In the next part of my presentation, I would like to focus a little bit on pathogenic mechanisms. I believe that the general understanding on pathogenic mechanisms gives us much better insider's view on the clinical phenotypes and in particular targeted therapy of this group of diseases. So I would focus a little bit more on inflammasome-mediated autoinflammatory diseases, or so-called inflammasomopathies. And I will briefly mention also diseases of interferon production and signaling, or briefly type 1 interferonopathies, diseases of NF-kappa B signaling and TNF activity, and briefly mention also inflammatory actinopathies. But at this stage, I would like to say that autoinflammatory diseases are very heterogeneous diseases. There are also some very rare autoinflammatory diseases mediated by different miscellaneous mechanisms that I will not focus in this presentation. An important concept in understanding monogenic systemic autoinflammatory diseases is that several of these diseases are inherited in autosomal dominant pattern. For this autosomal dominant pattern, it is characteristics that they are caused by gain-of-function mutations in innate immune signaling proteins. What does this mean? For inflammasomopathies, these diseases are characterized by gain-of-function mutations in genes encoding IL-1 activating inflammasomes. What are inflammasomes? These are large intracellular multiprotein complexes that are designed to cleave precursor pro-IL-1 beta into IL-1 beta, so highly inflammatory cytokine. And there are different types of inflammasomes. You can see here some of the recognized groups of inflammasomes, and all these are grouped under the umbrella of inflammasomopathies. The most common are pyrene inflammasome, and which causes familial Mediterranean fever, the defects in pyrene inflammasome, and the well-characterized NLRP3 inflammasome that is associated with cryopyrene-associated periodic fever syndrome. I will not focus on more rare inflammasomopathies. But before understanding the concept of inflammasomopathies, I would like to focus a little bit on node-like receptors, which are highly conserved cytosolic pattern recognition receptors. So these are our intracellular receptors that sense danger signals within our cells. Danger signals like some pathogens, like microbes, or damage within our cells. And if these node-like receptors sense this damage, they would start to oligomerize and activate this pro-inflammatory cascade. So this is a normal process in every human. And this is also the mechanism that is ongoing within every normal human that has no underlying mutation. The NLRP3 inflammasome and NLRP3 node-like receptor is very well characterized. On this slide, you can see that these receptors are normally in a kind of a hooked pattern, and this hooked pattern is very important that they stay in certain state of auto-inhibition or auto-repression. So they stay in a stable, dormant state. But if these receptors came into contact with some pathogens or some endogenous danger signals, they would open up, they would express their NACH domain, and they would start to oligomerize. And with this oligomerization, they would induce the apoptosis-associated speck-like protein, this C, and start the inflammasome formation with the cleavage of procaspase to active caspase, and this active caspase is a strong enzyme that contributes to cleavage of pro-IL-1 beta and pro-IL-18 in highly inflammatory IL-1 beta and IL-18. So this happens with danger signals. But what happens in persons who have underlying monogenic diseases called inflammasomopathies? So normal state is this auto-inhibited NLR protein, but with some inflammasomopathies, these patients have gain of function in oligomerization. So their NLR proteins do not stay in this auto-inhibited or auto-repressed state, but instead of this, they open up and they start spontaneous or constitutive inflammasome assembly. And you can imagine that this inflammasome assembly can start without any underlying trigger and can cause this systemic inflammation. And you will see in the following slides what are the clinical consequences of this uninduced systemic inflammation in these patients. What is important, if we know the underlying pathogenic mechanisms, that most of these inflammasomopathies that induces production of IL-1 beta producing inflammasomes respond to anti-IL-1 therapy. So we have a targeted therapy for this group of diseases called inflammasomopathies, no matter what inflammasome, either this is pyrine inflammasome, NLRP1, NLRP3, or other types of inflammasomes that induce IL-1 beta production. The second group of diseases that I would like to briefly mention, you probably heard a lot of information about type 1 interference also in relation to COVID-19. These are our receptor signaling for sensing intracellular nucleic acids, either from, let's say, some viral infections or our endogenous nucleic acids, and they induces these interferon pathways, and with the production of interferons, they would bind to type 1 interferon receptor and start the YAG-STAT signaling pathway, which is involved in several cell processes of cell differentiation. And with this enhanced interferon production, they would also cause somehow constitutive transcription of pro-inflammatory cytokines. The typical diseases are Aicardi-Couture syndrome, which sometimes resemble a picture of systemic lupus erythematosus with different organ involvement, or STING-associated vasculopathy, or called SAVI. The third group of diseases are NF-kappa-B mediated autoinflammatory diseases. NF-kappa-B is a final common pathway for many cellular cell activating stimuli. It is involved, it migrates from cytoplasm to cell nucleus and induces transcription of several pro-inflammatory genes, and typical diseases are Blau syndrome or haploinsufficiency of A20. At the end, I would just like to briefly mention also diseases that are caused by the defects in our cytoskeleton. So different disturbances in cytoskeleton are also associated with inflammasome production and pro-inflammatory signals. In this cytoskeleton is a kind of a very branched net of different actin filaments. And I would just like to highlight one of the proteins called ARP2, ARP3, which are crucial for debranching actually for branching of these actin networks, and with defects of this cytoskeleton formation, we can see a huge spectrum on a crossroads between autoimmunity, auto-inflammation, and allergy spectrum of clinical features. And I would just like to share one of our patients with this mutation that causes loss of ARP23 complex with actinopathy, with impairment in this cytoskeleton formation. And our patient presented with this huge range of clinical features ranging from infections, allergy, autoimmunity, and sky-high serum amyloid as a marker of autoinflammation. So to conclude my introductory talk, I would like to highlight that autoinflammatory diseases are a heterogeneous group of diseases. They can have several underlying mechanisms that are involved in regulation of inflammation, and they somehow illustrate the critical role of innate immunity. If we know the pathogenic mechanisms, we can also target therapies available for systemic autoinflammatory diseases based on pathogenic mechanisms. And I would particularly like to highlight the good response to IL-1 blockade in inflammosomopathies, and possibility to use YAC inhibition in type 1 interferonopathies to block the YAC-STAT signaling pathway. Most of the autoinflammatory diseases are rare. Only familial Mediterranean fever is more common disease. All other autoinflammatory diseases are very rare. And I'm looking forward to further presentations and discussions at the end of this webinar. At the end, I would like to thank colleagues from our department and the immunogenetic lab, and I would like to thank some of our sponsors and networks within Europe where we collaborate in treating and caring for patients with systemic autoinflammatory diseases. Thank you very much.
Thank you, Professor Avcin, for your informative presentation. The next presentation is by Professor Sophie Georgin-Lavialle on recognizing side symptoms. Professor Georgin-Lavialle, please introduce yourself, and you may start whenever you're ready.
So I am an adult practitioner. I work in the French Adult Reference Center for Autoinflammatory Disease, and I am an internal medicine specialist, and I also am a clinical immunologist. So today I will speak about recognizing SAID symptoms for general practitioner and or pediatrician. So as you will see, I also chose some adult little picture and features for the general practitioners. So the first thing is how to make SAID diagnosis. So in front of which symptoms do we need to think about those? This picture, I think it symbolizes a lot what's happening is that usually the patient will not have a lot of symptoms when he's in front of you, because maybe he will not consult you when he's in crisis, but inside there can be inflammation which can be visible or invisible. So that's, I think, something very difficult in those diseases. It's something which is not always visible, but it can be burning inside, or it can be cyclic burning with cyclic fever. So there are some elements in favor of SAID, some positive features with the timeline. So for adults, we always say that it has to have been begun 6 months before. Of course, it's different for children because we don't wait for 6 months to think about those diseases when they begin very early in life. And then usually there are recurrent attacks, especially with fever, but some patients don't have always fever. And then something very important is that fever is not naked. And the three main systems that are involved are the skin and the mucous membrane. and we will see some pictures. And then the musculoskeletal system, the digestive tract. And one very important thing is the biological signs with biological inflammatory syndrome in crisis. And as my colleague just told you, there are some very rare diseases which are called interferonopathy. In those diseases, the inflammation can be very, very low or absent, but in the most common autoinflammatory disease, especially familial medical fever, there is an important inflammatory syndrome in crisis. So these are the positive features, but there are also some negative features. So the patients have no infection, no chronic infection, no neoplasia, almost no antibodies, and almost no immune deficiency. I will not go in the details because some of these are very, very rare, but I said almost because very few of them can have some antibodies and immune deficiency. But I think we have to keep in mind some important advice, and the most important is that there is usually no antibodies and no immune deficiency. Then something very important is how to think about the disease is to check out the timeline of the patient. So on the left side, you can see a baby or a child. So I will maybe my colleagues who are two pediatricians will speak about that after, but I think in a baby or a child, you can evocate those diseases quite early, even if the baby is only 1 or 2 months old. Whereas in an adult, so the right part of the slide, and this is my specialty, we usually take a 6 months delay between the onset of symptoms and the possibility to evocate systemic autoinflammatory disease, except for one, which is adult onset still disease, which can be very explosive, and we can evocate this disease much earlier than 6 months when the fever arrives. Then we were speaking about fever. So fever is one of the most frequent symptoms of the disease, and it can be seen like this. The curve I show you. So it can be recurrent fever with in between the episodes the patient has no symptoms, or it can be recurrent fever and a chronic background of clinical or biological inflammation, which means the CRP, for example, can either be elevated in between crises or come back to the normal in between crises. So the 3 main organs I told you about are the digestive tract. So we will speak a little bit about later. So you have a patient with fever and or recurrent fever and digestive symptoms, the cutaneous or mucosal symptoms, and I put here an example. So on the right you see the skin, and on the left I wanted to show you the oral aphthous that can be also bipolar, but oral aphthous are quite frequent in those diseases. And then the musculoskeletal symptoms, which can be located on the joints and or muscles, and usually are not erosive, but in some cases can be. Another, we were still in this part, which is how to think, how to evocate SAID. Another one is, I don't know what my patient has. It's an enigma. I don't understand the problem, but there's inflammation. So then you can evocate systemic autoinflammatory disease. Another situation is this one, is you tried so many medicines and neither of them is working. It means you miss your target at each time, even though you have tried many, many different possibilities. And usually it means that classical medicine are not effective, and maybe it's because you haven't tried one target on, for example, IL-1 or interferon, just as my colleague told you. Some clues that are very interesting is the familial transmission. So whenever you have a patient with an enigmatic symptomatology, I advise you to draw the familial tree and to look for autosomic dominant transmission, just my colleague told you, or for consanguinity, which can be evocative of recessive disease. And another very important feature is when you have a patient, usually an adult, hopefully and luckily, with AA amyloidosis. So the most frequent way to diagnose AA amyloidosis is a nephrotic syndrome, and then there's a biopsy which is performed. And here on the left, you can see a glomerular biopsy with the staining against SAA, which is a specific, is an unspecific inflammatory biomarkers. But when there is a SAA staining in a patient with amyloidosis, it is in favor of AA amyloidosis, and it can reveal an auto-inflammatory disease. So now that we have seen the symptoms that we have to think about SAID, we will see the most common symptoms. So on the left, at each clamp, you will see the organ. And so here we are in the digestive tract. So the most frequent symptom is the abdominal pain. And of course, for the most frequent of them is the familial Mediterranean fever, but some other can manifest themselves by abdominal pain. With or without fever, mostly with fever, sometimes without fever. So it's very important to get a CRP measurement at the time of the abdominal pain to see if there's inflammation, even though there's no fever. Then when we look at the skin and the mucus, the skin is very, very informative. Here you can see erythema of the ankle, which is called the pseudoerythema in familial Mediterranean fever, but the skin is not also interesting. The mucus is very important. So here you see oral aphthae that can be bipolar. The patient can also have chronic aphthae or cyclic aphthae. Can have one or many. And also very informative feature is the urticaria. Recurrent urticaria, especially if it's favorized by the cold-induced, can be revelative of rare inflammatory, which is called cryopyrin-associated periodic syndrome. And then, as I am an adult, a new disease was discovered 1.5 years old, 1.5 years ago by our colleagues in the NIH in the United States, and it's called the VEXAS syndrome, and it's associated with somatic UBA1 mutation in the NF-kappa B pathway, and it is associated in about 40% of cases with recurrent polychondritis. So here you can see an example. If you have an old patient, especially men, with inflammation, anemia, and recurrent polychondritis, it's very evocative of this new disease. Then for the musculoskeletal system, the symptoms are usually not specific, and there can be muscle pain or articular pain. And then on the left of the side, you can see this integrative point, and I will say, when you don't know what your patient has, but he has like uveitis or inflammation of the eye, and he has deafness, and he has neuroinflammation, for example, recurrent aseptic meningitis, you can evocate those diseases. And to finish, I will show you an example of clinical cases on the last quiz. So this is a woman, 18 years old. As you can see, I took 18. It can be still for pediatrician or adult. And she has recurrent episodes of fever from 2 to 4 days since she was young, and she presents very frequently every month eruption of the ankle that are swallowing and that are very painful, and she can't walk. So she has also recurrent abdominal pain with fever during those 2 to 4 days, and she's originating from Egypt, for example. So what is your diagnosis? Maybe you can vote in the chat, and Malena or Emna will tell us if you find the right diagnosis. So she can also be originating from Turkey or from Tunisia or from Morocco. So what is your diagnosis? So some of you already found and voted for familial Mediterranean fever. So yes, you're right. So it's the most frequent auto-inflammatory disease. And as my colleague just told you, it's an inflammatory with an excess of IL-1. And here is a resume of this disease with most frequently fever and abdominal pain during from 2 to 4 days with mutation in the gene which is called MEAV for Mediterranean fever. So just to finish, because it's very new and maybe some of the general practitioners that are listening to us will make diagnosis thanks to this, I will show you the story of a French 74-year-old man coming from a family where nobody is sick, so it's a sporadic case and his parents are not consanguineous. And he presented some very impressive eruption, maculopapular eruption, with conjunctivitis and recurrent polychondritis of the ear and nose. He had anemia at 9 grams per deciliter and elevated VGM with a lot of fever, and it was VEXA syndrome, which is this new disease, and there are actually probably more than 200 cases in France and probably more than 500 cases just in 1 year in the world, so it's not so rare. And maybe you can evocate that disease when you have an old man with inflammation and you don't understand why, especially if he has macrocytic anemia. So in conclusion, when to evocate systemic autoinflammatory disease, it's in front of a patient with recurrent fever and abdominal pain, features of the skin or mucosa. Also, you can think between of deafness and eye involvement. Maybe the patient can display AA amyloidosis, and please never forget the most frequent of them, which is familial Mediterranean fever. And I thank you for your attention.
Thank you, Professor Georgin-Lavialle, for that very interesting presentation. And now we have the final presentation by Professor Isabelle Koné-Paut on Access SAID Specialist and Patient-Centric Care. Professor Koné-Paut, please introduce yourself and you may start when you're ready.
Hi, so expecting that everybody hear me. So I am Professor Isabelle Koné-Paut. I am a pediatrician. I am a pediatric rheumatologist, and I am heading the referral center for auto-inflammatory diseases in Paris. So I am very happy to be here, and so I will give you this presentation, access to specialized and patient-centered care. So there is a lot of challenges around the diagnosis of auto-inflammatory diseases. As said before, these diseases are very rare, but even we take the example of familial Mediterranean fever, you can be in a country where the disease is very frequent, so you may think about the diagnosis very early. But as you see in France, the prevalence is estimated 20 for 100,000, so it's even rare, but you may really encounter these patients, so it's important to recognize them and to address them quickly to an expert physician. There are other diseases which are ultra rare, I could say, like, for example, mevalonate kinase deficiency or TRAPS, and you can see that their prevalence are very low. And for these patients, the diagnosis may take a lot of time, because if you are not, I could say, you have not awareness on this disease, really, it's very difficult to recognize. And also you can see another diseases, which is CAPS, and the prevalence in France has been estimated at 1 to 360,000, so it's also a rare disease. So this is because, and this is in consequence, we have low physicians' awareness of this disease. There are also a number of misdiagnoses before the right diagnosis is done. And also there is a diagnostic delay, which is really very bad for the patient. And even it has decreased in the last decade. We know that the median time before the onset of the symptoms and the diagnosis may be still too long. And for example, here we estimated from 1 to 2 years. So early diagnosis is something very crucial to enable the treatment initiation before the patient has too many damage. So I would like to, okay. So this is rather old, because it is a 10-year representation from 10 years ago, but you can see that we had at this time an important delay between the age of onset of the disease and the age at the diagnosis. And the most the disease was rare, and the later the diagnosis was made. And you can see here that FMF has the lowest diagnosis delay at this time. And you can see that for the ultra rare, like TRAPS or in NLRP12, which is very rare, we had quite a higher delay. And you can see that with time, this diagnosis delay tend to reduce, and this is something very good. And because probably the referral of these patients has probably improved. So what are the factors that contribute to diagnosis delay in these patients? And I will take the example of the mevalonate kinase deficiency. This disease, as you see, is ultra rare. It's an autosomal recessive autoinflammatory disease. And to date, there is around 300 patients reported worldwide. And you can see that the prevalence estimates is not well known because it's so rare. It has been estimated in Eastern and Central European countries at 1.3 per 1 million of children aged to children. And you can see that in the Netherlands, where this disease is considered a little higher, the prevalence has been estimated as 5 per 1 million. And in Germany, they have made an estimation of, sorry, but I try to avoid this. I cannot, okay. So you can see that in Germany, they do better statistics, that the prevalence is 6.2 per 1 million. So it's still very low. And you can see that the incidence is even very low at 0.39 per 1 million persons in Germany. So at present, we believe that this disease is very rare, of course, but we can see that there are some difference between countries because the diagnosis depends on physicians' awareness, and it is very elevated in the Netherlands, where the disease has been first described. We know also that some patients may never be diagnosed because they may have mild symptoms, for example, or as the contrary, because they have excessively severe with early mortality, and the diagnostic is not recognized because the death is coming so early. There are also atypical phenotypes with misdiagnosis, and some of these patients have been diagnosed with systemic GIA, and in some cases, the inflammation of the bowel is the main symptoms, and it's why the disease must be postponed. And also, it's important to have the adequate resource available to make the diagnosis, and also to have diagnostic testing and especially metabolic and genetic testing available to make the right diagnosis. So there is a lot of parameters that can influence to make the diagnosis early. So you can see here what is that to make a diagnosis and to refer a patient at the right place is something very complex. And you can see here an example of a very complex network. And as the patient has his first referral at the right place, he needs to have appointments. Sometimes it is more than one appointment. And also the diagnosis can require non-invasive investigation first. So after invasive investigation, and after there is a long way sometimes to have a definite treatment. And in parallel, we have really to work on all the information on the disease, to have a database, and to study the pathway of the disease and the patient pathway too. So it's something very complex that involves a lot of systems that are not always in connection, and it's why it's very important to have a common efforts and a very connected effort around these patients. And so it's why there was a first national plan for rare disease in France that started in 2014, and it was pushed by patients associations, And their main goal was to reduce the diagnosis impasse and to also facilitate the referring of patients to reference centers. And so it was launched in 2004, and at this time also was launched the first Orphanet portal, where we can find the list of diseases and a lot of information about these rare diseases. And after this first plan, there were 2 successive national plans that have strengthened French leadership in the fight against rare diseases. And these have finally ended with the creation of 23 health sectors based on 387 reference centers. And also, these reference centers have their proper network of competent centers. And this is aimed to cover all the French territory and to permit to each patient with a rare disease to have a chance to encounter a specialist and to be followed and cured in a standardized manner. And so you can see that this year there will be a third plant, and it's also very important. What is the core of this network is to build also care research and education around rare diseases. So you can see that there is different levels in this rare disease network. So in France, the first level was built with those reference centers. And you can see here the reference center of the Ceremaya, which is the reference center for auto-inflammatory diseases. They are figured here in pink. And you can see all the competence centers around the referral centers, and you can see that the aim is to cover all the French territory. And there is you can see here all the reference centers from the Ceremaya. And after this level of reference centers, there have been an effort to gather together the reference centers that are treating patients with the same types of diseases, and it's why the Systemic Autoimmune and Auto-Inflammatory Disease Network, called FI2R, have been set up to connect all these centers and also to favorize research, education, and also to connect better with patient association, etc. And around this, we may have care assistant platform to connect all the specialists like physiotherapists, nurses. And one of these systems exists in the area of Paris. It's named RESRIP, and this is very important also for patient education, connect with school, etc. And as you know, there have been another effort at the European level with the creation of the ERN, and we belong to the ERN RITA. So you can see that there are different levels, but with time, the organization around rare diseases is improving with the same aim to improve the patient care. So this is our reference centers. You can see that I lead these referral centers, but we have 4 sites. We have a site in Versailles that is led by Véronique and Jeanne. We had a site in Montpellier, led by Isabelle Koné-Paut, and a site in La Pitié-Salpêtrière, led by Professor Sadoul, and a site in Tenon, which was previously led by Professor Gratteau, but is now led by Sophie Georgin, that you have heard just before me. And you have here all the list of competence centers around our referral center, and you can see all the specificity of the different sites, because one important thing is that we need to be complementary, and this is something very important for referral centers. So what is the pathway of the patient in the Ceremaya? So we have a first referral, in general from a GP or a pediatrician or an hospital specialist, and by this referral, the patient may be seen at a consultation or directly in hospitalization. It depends of the disease. And we do the initial evaluation. And of course, the first level is to identify the diagnosis, and for this we have several procedures: clinical, biological, radiological. If the patient phenotype fall into something which is genetic, so we can make a genetic testing. When we have the diagnostic, you have the announcement of the disease, and after we have the plan for treatment. And around that, we can also organize care pathway and patient education. When it's possible, we use a raspberry. When it's not possible, we use leaflet, movies, serious games, and we have a number of tools in our reference center, but also with our network FAID. For some patients who are very difficult, or when the patient is not really coming from a referral center, we can organize multidisciplinary consultation meetings where we discuss the accuracy of genetic testing. We can also discuss for treatment of the patients, and we have our own MCM in the Ceremaya, but there are also MCM in the FAID. And so it is something now that is really well organized. And after, around the follow-ups of the patient, we evaluate it clinically, measuring disease activity, damage, quality of life. Some patients require a genetic counseling. Sometimes we have not a diagnosis with the first level of genetic testing, and so we need further genetic research, and it includes whole genome sequencing. And for that, we have also a multidisciplinary consultation meeting to choose which patients must have this type of strategy. And also, we can discuss new therapeutic strategy. And also, because it's also in the mission of a referral center, we have to organize the transition of care to adult centers. And because we are a reference center, we are very involved in clinical research. And so we have, we participate in several data repositories. We have our national rare disease repository in France, which is named BAMARA. We participate also to the GIR cohort and also to the Eurofever cohort. We also participate in the ImmunAID. That is very important because it contains multi-omics investigation for our diseases. We participate, or we also design drug trials because we want our patients to have better care of their disease. And also we have many clinical studies to improve also our patient health. So this is an example of our national data repository for rare diseases. And this is an example of our site in Kremlin-Bicêtre. And so we enter regularly of our patients when we see them in consultation or in hospitalization. And you can see that we can have the statistics of our activity, the number of patients we see by a year, the quality of the data that we have entered, and a list of diagnoses with the number of patients that we have seen. So it's also something convenient to have the statistic of our proper centers. So what are the possible treatment and strategy in autoinflammatory diseases? So it's not always, and more often, it's not possible to cure the patients, but we can do the minimum. And one of the minimum we can try to do is to make the symptoms disappear. And in general, as these diseases are basically inflammatory, we can use not specific approach using NSAIDs, colchicine, or steroids, for example. Even these latter are not usable for a long time because there are too many side effects. If it is available and if we have more knowledge on the pathway of the disease, we can trigger specifically some cytokine, for example, and you can use more targeted biologicals or small molecules. So this approach really has demonstrated that we can improve the quality of life of the patients, and we can also lessen organ damage. But in this case, supportive care is still needed because really we cannot cure the patients. So there are other approaches, and here the main aim is to cure the patients, and it has been done in some rare diseases. And one approach which is available is hematologic stem cell transplantation in some case. And also gene therapy is something available, so not directly in systemic autoinflammatory diseases, but it will be available, and there are some plans, to my knowledge, at least for mevalonate kinase deficiency. And the aim is to replace the defective gene by a normal gene. You can also repair or eliminate a gene that is not functioning, or not functioning good, or functioning too much. And there are some techniques to do that. And we can also modify the RNA, the messenger RNA, using antisense nucleotides. So technologically, it is feasible. It needs some improvement, but it's something that the patient can really expect for the next coming year. But of course, it is just accessible for the disease which are clearly monogenic. We need to identify the causative gene for making this type of therapeutic approach possible. And also we have to, of course, to have the availability. Also, we have to assess the safety. It's high cost. So for the moment, it will be restricted to selected patients. So this is an example of the therapeutic targets for monogenic autoinflammatory diseases. If we cannot cure the patients, we can relieve the inflammatory symptoms. And you'll see here the different types of autoinflammatory diseases. We know the inflammatory pathways, so we can target the pathways depending of the group of patients. We can block the IL-1, we can block the interferon, we can block the TNF. It depends on the type of the disease, and it is something that is at this time very effective in a lot of these diseases. And so, you know that, of course, as referral center, we have to think about personalized medicine. And for that, we need to have a very good characterization of the disease and to treat it specifically. So at the beginning, we have patients who may be different, but they have all in common an inflammatory phenotype. So when we are at this stage, we try to identify patients that look like together into a disease, and we make some classifications. If we can go and we can identify an autoinflammatory phenotype, at this time, if the pattern of the disease is Mendelian, we can make a genetic diagnosis. If we have a genetic diagnosis, we can do functional research, functional testing, and this functional test may allow to better identify the pathophysiology of the disease. And if we identify the pathway that is related to a disease, so we can, at this time, develop specific treatment. And this is one aspect of the Immunode project. In other cases, we have clinical phenotypes which are related to autoinflammation, but the disease does not appear Mendelian. It's quite more multifactorial. So it means that we have not one gene, we may have several genes, and even we have several genes, there are other factors. And for this, the genetic diagnosis is quite impossible or quite more difficult, but we can identify the gene which participate to the phenotypes and their proteins. We can also study their interactions, and after, by this way, progressing to individual treatments. And this is also one aim of this very important Immunode project, the ImmunAID project. So we can see that all this needs coordinated efforts, different specialists, different discipline of medicine, immunology, and so I think we are really on the good way. And I thank you for your attention. This is the team of the Soremaya that is now make a smile to you. So thank you very much for your attention.
Thank you for your presentation, Professor Koné-Paut. As always, it was very informative. Anyway, on behalf of ImmunAID and FMF&AID Global Association, I would like to thank all the speakers for volunteering their time and for their insightful presentations. Thank you.
Bye-bye.
Thank you, Malena.
Thank you all.
Yeah.
Thank you, everyone.